webinar. I'm Nicola Batossi. I'm CEO of Fertility New Zealand. It's my absolute pleasure to welcome you tonight and introduce this evening's speaker. For those of you who don't know, Fertility New Zealand is a registered charity, and we exist to hold the hand of Kiwis who are wanting to build whānau. We do that in a variety of ways. We have information available on our website and through our 0800 line, support groups running around the country, and we represent the voice of Kiwis facing fertility challenges. So without further ado, I would like to introduce Dr Olivia Stuart, who is our speaker for this evening. She is a fertility specialist, obstetrician and gynecologist in Auckland. She operates practices at Fertility Associates in Auckland and also at Auckland Hospital. So thank you very much, Dr Stuart, for your time and expertise this evening. If anybody has any questions, please type them into the chat box at the end of the presentation for them to be answered live on screen. Okay, over to you. Thank you.
So tēnā koe, Nicola, and thank you so much for Fertility New Zealand for asking me to speak. Tonight I'm going to be talking to you about common causes of subfertility for men and women and the various options that are available to you. The Dunedin 1,000 people study gives us the most recent evidence that 1 in 4 people experience fertility in New Zealand by the age of 38, and that's much higher than what we previously thought. Female and male causes contribute equally, with about 40% of either contributing to their infertility and the remaining 20% either being combined or unknown. Firstly, I'm going to start looking at causes of female infertility. Right. So what we know is that men make sperm every day for the rest of their lives, but you may or may not be aware that as women we're only born with our eggs. We don't make any in our lifetime, and in fact we're losing eggs as we're getting older. We're born with about 1 million eggs. We ovulate about 400 in our lifetime, and the rest unfortunately die by a normal physiological process called apoptosis. By the age of 35 we have about 10% of our eggs left, and then by the menopause that's when all our eggs have run out. There are a few factors that can help us predict the timing of our menopause, however. It's definitely worth asking your mother what she did, if you can, because 10% of the time we do what our mothers have done. Or if an older sister has gone through early menopause, then you could be at risk of doing that too. So coming to see us early if you've got a family history of early menopause is essential. AMH is essentially the hormone produced by eggs left on our ovaries. So it's the best test for us as women worldwide for knowing and finding out how many eggs we have left. As we're getting older, our egg numbers and our AMH blood test result are going down. But for every age group, there is a normal range. So if we get an AMH in the normal range, we've got a normal number of eggs for our age group. We're going to have a normal menopause around the age of 51. If our AMH is in the lower range or in the red zone for our age group, then we know that we're going to have an earlier menopause, usually in our 40s or sometimes earlier than that, and a shorter time to have our own biological child. The AMH test isn't funded, unfortunately, and it usually costs about $90 to $120 depending on the charge from the lab you're getting tested by. The pill can falsely lower it, that being the combined oral contraceptive pill. So being off the pill for ideally 2 to 3 months before you get the AMH test done will give you the best true reflection of your ovarian reserve. Not only do we have fewer eggs as we get older, which means we have a lower chance of pregnancy as we get older, but also we're hit with a double, triple whammy as women, because our eggs are the same age that we are. So they're more genetically abnormal as we get older, which are more likely to make genetically abnormal embryos as we get older. So our chances of miscarriage and having a baby with a chromosomal abnormality such as Down syndrome also increase. For women with regular 28-day cycles, it's easy to predict ovulation and to time sex at home. We typically ovulate 14 days or 2 weeks prior to the next period, so around day 14. But once ovulated, the egg needs to be fertilized immediately, otherwise it dies within 24 hours of ovulation. So the sperm essentially need to be ready, waiting in the tubes for the egg to present itself to fertilize the egg. So the highest chances of pregnancy are actually when we have unprotected sex 2 days prior to ovulation, and so that's typically around day 12 in a woman with a regular 28-day cycle. But sperm can last in the system for up to 5 days. So covering all your options by having timed intercourse on day 8, day 10 and day 12 will actually give you the best chance of a baby. The main causes of female infertility are failure to ovulate, so irregular or absent ovulations, tubal occlusion, endometriosis, and age-related concerns. There are many things that you can do at home to try and optimize your chances of pregnancy. A diet rich in antioxidants, such as the Mediterranean diet, is key, and that links into regular exercise and weight optimization to give us the best chance of pregnancy. Smoking, both for men and women, and even if the male is a smoker and the female is a non-smoker, will be halving your chances of getting pregnant, more than doubling your risk of a miscarriage. And so this is why females and males both have to be non-smokers before they'll get funded fertility treatment in New Zealand. That's how important it is. Alcohol consumption in moderation is key. Having a couple of days off a week, 1 or 2 standard drinks a night. Avoiding binges for men, because binges are a very good way of knocking out sperm production, and it takes 70 days for sperm to regenerate. Having 1 or 2 coffee shots a day is quite fine, but anything more than that can reduce your fertility. Now we're going to look at causes of male infertility. And there are multiple factors which can affect sperm production, mature sperm and sperm transport. A low sperm count can even occur physiologically, where a fertile man once performed a semen analysis every 2 years, and despite having mostly normal counts, several times he was below the normal range. So sperm production is not a primary function of the body, and it can switch off at times of unwellness in favour of more important bodily functions. Many things can do this for a guy: a drunken binge, being sick or unwell, and of course the life-threatening man flu. Sperm production is quite an inefficient process, and sperm anatomy is one example of this, where the lower range of normal is actually 4%, meaning men only need at least 4% of their sperm to be normal in appearance to have normal fertility. There are many lifestyle factors which men can make to improve their fertility. Normal BMI is key. Just like with women, the extremes of body weight, such as underweight or overweight men, is a powerful suppressant of sperm production. So guys that are obese typically have poorer sperm quality and low testosterone levels, which can be normalized by them optimizing their body weight into the normal range. Again, with women, dietary antioxidants, so a diet rich in antioxidants such as the Mediterranean diet, again, is very important. So high in vegetables, fruit, fish and whole grains. Good evidence to show that diet rich in antioxidants is equivalent to having an antioxidant supplement. So we only advocate antioxidant supplement if people feel that their diet is insufficient. Minimising alcohol that we've talked about, no cigarette or marijuana smoking, as we've already talked about, and frequent ejaculations is another important thing for guys, and we'll talk a little bit more about that later. Avoiding excessive heat, so guys that are on long bike rides on a daily basis, taxi drivers, truck drivers where they're sitting on a heated engine is again not ideal for male factor issues. The testes are out of the body for a good reason. It's too hot inside the body, so heating up the testes has a detrimental effect to sperm production. So some men think that banking up your sperm for a few days is better, but actually all they're doing is storing up the old dead sperm. They're making millions of sperm every day, so they need to be ejaculating often, and we usually don't hear many complaints when we advise this, for men to flush out the old sperm and let all the new sperm come through. Oh, sorry. As our ways of creating families diversify, so do the options available for us to help you. Our first consultation always starts with history, examination, and then investigations. For females, an examination involves a pelvic ultrasound scan looking for any lumps or bumps in the uterine wall and the lining of the uterus and on the ovaries. And if men have a low count, a male examination includes checking testicular volumes, checking for any testicular lumps, and the presence of the vas bilaterally. The basic investigations for females are a day 2 to 3 hormone profile to check the hormones which control ovulation, an AMH test, and an HSG or a high-COSY tubal patency test to check for tubal occlusion. For men, the basic examination is a semen analysis. Your local lab can do a basic sperm check looking at 3 things: volume, count, motility, how well the sperm swim. Whereas a fertility lab can actually check for 5 known causes of male factor infertility. Those 3 plus anti-sperm antibodies and sperm morphology or anatomy. We're going to look at different scenarios, and so the first one is a couple with unexplained infertility with regular cycles, patent tubes in the female, and a normal semen analysis in the male. The various options are available to them, and so broadly these are ovulation induction, where the woman takes medication to produce 1 or 2 eggs that month. We do monitoring with blood tests and a scan to check she's responding and not over-responding. And then we know when ovulation is occurring based on those test results and when the best time to have sex for them is. The second option is IUI, and again, the woman takes medication to produce 1 or 2 eggs. We monitor for ovulation, and then we take her partner's sperm, wash it down, prep it, and put it into her uterus at the right time. IVF involves a woman having injections to stimulate her ovaries to respond to make as many eggs as we can. We take those eggs from her body, fertilize them with sperm in the laboratory to make embryos, and then put the best embryo back into her uterus and hopefully have more embryos to freeze. Basically, the more we do, the higher the chances of a baby, but the more involved and the more costly it can be. Polycystic ovarian syndrome is the commonest condition in women of reproductive age group and is diagnosed by having 2 or more of the following: irregular or absent periods, increased acne or hair production around the face or the belly button in the male distribution, or a high testosterone on a blood test, or having polycystic appearing ovaries on ultrasound scan. So you need 2 of those to make the diagnosis. The way polycystic ovarian syndrome affects fertility is that it makes it harder for men and women to time bringing the egg and sperm together, because the ovulation is either happening very irregularly or absent, compared to the woman that's having ovulating once a month. Women with PCOS, first-line treatment is something called letrozole nowadays, which is much better than the previous medication that we use called clomiphene, at making just 1 or 2 eggs develop each month in a woman with PCOS, compared to clomiphene, which is really good at making lots of eggs develop with a woman with PCOS. So you've got a higher chance of ovulation and pregnancy, a lower side effect profile because it doesn't linger in your system as long as clomiphene does, and a lower multiple pregnancy rate of 3% compared to 7% with clomiphene. So for many reasons, with women with PCOS alone, patent tubes, normal sperm, we would use letrozole ovulation induction. Endometriosis is present in 50% of women with subfertility. There are symptoms of endometriosis, but it is a funny condition where you can have extensive disease with no or minimal symptoms and severe symptoms with minimal disease. What we do know is that mild disease is less likely to affect your fertility, and more severe disease is more likely to cause subfertility, and that you're more likely to require fertility treatment. It does this by creating an environment of inflammation within the pelvis, distorting anatomy, and reducing ovarian reserve in some cases. So women with tubal patency and normal or mildly abnormal sperm, or with mild endometriosis, we can do IUI, which is intrauterine insemination, where we just need to have at least 1 million motile sperm to have sufficient pregnancy rates, and we combine ovulation induction either with clomiphene or letrozole to ensure 1 or 2 eggs come out each month, and then take the partner's sperm, wash it down, prep it to get the best of the best, and then put it inside her uterus at the right time. Blocked tubes are very common in women and usually are due to infection or inflammation months to years ago, usually caused by chlamydia or gonorrhea. Unfortunately, it's not reversible, as removal is associated with healing, scarring, and a high reformation rate. So the best chances of conception after blocked tubes is IVF, which bypasses and doesn't need fallopian tubes. IVF is the process where a woman takes stimulation injections to stimulate her ovaries to respond to make as many eggs as we can. We take those eggs from her body with a procedure under sedation. We combine them with her partner's sperm in the laboratory to fertilize her eggs to make embryos. We put the best embryo back into your uterus and hopefully have more embryos to freeze for more goes. The next slide shows you how IVF pregnancies in the red always double or triple your chances of conception over our middle treatment, which is IUI. But as you can see, as a woman gets older, our pregnancy rates go down even with IVF, so it can't overcome the age of the egg as well, where it drops from the mid-30s and significantly from the 40s. So the only way to overcome this is by using an egg donor from a healthy young woman. So a couple with endometriosis and low sperm count, they need treatment to have a baby. And if the endometriosis is significant enough as the sperm abnormality, then they'll qualify for public fertility treatment. And sometimes they may opt to private treatment while they're waiting for their public treatment to come up. A common scenario we're seeing more and more nowadays is a single woman wanting to have a baby in a family. Some want to start today, and others come early because they want to plan for their future. Single women should be put on the donor wait list as soon as they can, due to the wait time that we often see, which can be around 18 months until they get to the top of our sperm donor wait list. They can either wait until they reach the top, or they could start recruiting, and the best plan if they want to do that is to see our counsellors, which is an essential part of the process, because they can also show you where people advertise, where you can advertise, and to give you language to communicate with people that you already know that you might not know what language to ask them. Then once the donor is available and they go through the necessary medical review, testing and quarantine, then you're ready to start using their sperm to have a baby, either with IUI or IVF. For those single women not ready to have a baby right now, but are adamant that they want to have a baby, and they might be waiting to get to the top of the wait list, or they might be waiting for Mr. Right, they undergo egg freezing. And it's essentially half an IVF cycle and involves injection for 10 to 14 days, an egg collection under sedation, egg freezing, and then IVF later on down the track with the donor sperm or their future partner. Natalie had similar concerns and had just broken up with her partner and always wanted kids. So she chose to freeze her eggs. She joined our sperm donor wait list. Then a couple of years when she got to the top of the wait list, she thawed out some of her eggs, combined it with the donor sperm and had a baby Grace. A couple of years later, she met Mr. Wright, Anthony. They decided they wanted to have children together, and instead of using her 40-year-old eggs at that time, which had a much lower chance of a baby, she chose to thaw out the rest of her 35-year-old eggs, which gave her a much higher chance of a baby, and go through IVF using Anthony's sperm. And so we're more and more able to help same-sex couples as well. Leanne and Luella both are ready and want to have a baby. They can choose to either use the same donor with IUI if their tubes are open, or with IVF if they want a higher chance of a baby, and in considering having more than one baby each. They can also egg share, where one partner uses her eggs and the sperm donor to make embryos, and the other partner carries if only one partner wants to carry. Certainly due to her age, Leanne's eggs at 33 would give them the highest chance of a baby, but if Luella really wanted to have her own biological child at the age of 40, then starting with her eggs ASAP would be the first best option. For John and Dean, the process is a lot harder, but still possible, and we are helping same-sex male couples more and more. They need an egg donor and a surrogate. They require extensive counselling, an ethics committee approval, surrogacy lawyer consultation, SIFS application, and they need to adopt their children after the birth, because in New Zealand, the birth mother is legally the mother. Some same-sex male couples team up with same-sex female couples so they can share their eggs, sperm and uteri to have their families. So these are reasons why you should see a fertility specialist sooner rather than later. If you're over 35 and have been trying for at least 6 months to have a baby, if you have irregular periods or absent periods, or if there's a known sperm factor, if you know that there's tubal occlusion at least on one side or both sides, if you've had a history of recurrent miscarriages, a family history of early menopause, if there's genetic conditions in your family which are passed on through the generations and are keen to eliminate those conditions from your offspring, same-sex couples, and those considering fertility preservation. There are various ways to see us. You can self-refer. You don't need to do any tests. You can just call up and we can see you within 2 weeks privately. Or you can see your GP for a public consultation, who will need to organise specific tests first. And you could be waiting 3 to 4 months for an appointment, and you won't be able to control which clinic or which doctor you necessarily get to see for that appointment. We also have free nurse consultations online with a link on our Front Fertility Associates webpage. So thank you very much. So yes, Nikki, this is very common. Typically guys are less keen to want to ask for help because of the stigma, maybe particularly associated with asking for help. It sort of goes in keeping with them not really going to see the GP as well. So, I mean, things that you can do is you could still come and see us. You could, on your own, you could at least get some initial advice from a nurse consultation. But certainly 2 years without success, we would expect to find something when we did investigations, because what we know with fertile couples, 85% will conceive within a year, 95% within 2 years. So 2 years of trying without success is something significant, and it's highly suggestive that you're going to need some help. So one tube doesn't just give you partial points, unfortunately. So no, just from the history you're telling me alone, for unprotected sex for 1.5 years and one tube patent, that alone doesn't give you sufficient points, unfortunately. But you're still well within, one suggestion I would definitely advise you to do is either to come and see us, come and see a fertility specialist. Whether you do that privately or through your GP is important, because if you've had one tube blocked that has made an ectopic, then the chances of the process going on in the other tube is likely as well. So it would be important for you to have a tubal dye test as well to check the other tubes. Okay. So in response to Hannah, it depends on the embryo development between fertilization and day 5. So up until day 2, day 3 is when the egg DNA is active. And so if you've got good embryo development from up until day 3, then it's less suggestive of an egg issue. And if there's poor development from day 3 to day 5, then that's more suggestive of a sperm issue. But it would be having to have a look at in more detail at your history and results and that particular cycle to have a proper educated answer to your question. So it depends on the extent of male factor infertility. So certainly mild male factor infertility is, you could certainly still get pregnant naturally or through simple treatments like ovulation induction or IUI. It depends on what factor is involved with fertility. We saw how much sperm count can be affected by just simple events in a guy's week, but there are particular things that are significant, such as high abnormal morphology, anatomy of the sperm, high anti-sperm antibodies. I mean, those are definite indications that a special type of IVF called ICSI is needed. So it depends on what's actually the problem with the sperm in regards to trace.
I think that's all the questions for tonight. So that concludes our webinar, which was really useful. I mean, it's such a big topic, but it was a great overview. Tomorrow night's webinar is self-care during infertility, which is really important for anyone, no matter what stage of a fertility journey you're at, with Joy Ellis, who's really well renowned in the area. So I would just like to say a very big thank you on behalf of everybody here to Dr. Olivia Stuart for presenting tonight's Fertility Week webinar. Thank you very much, Dr. Stuart, and for everybody else for coming along.
Thank you, Nicola. Ngā mihi.
Okay. Good night.